a consortium of hospitals dedicated to the education, research, and provision of emergency pre-hospital care. The center also provides medical command for the city of Pittsburgh. The subject of this lesson is pre-hospital burn care. About 2 million burn injuries occur each year in the United States. An average of 30 people die every day from burn and inhalation injuries and associated trauma. This lesson, pre-hospital burn care, will address assessment, the ABCs for burn patients, and early recognition of inhalation injuries, the #1 killer of burn victims. Assessment of burn size and depth will be discussed, and recognition and treatments for thermal, electrical, and chemical burns. Finally, the subject of pain will be addressed, and wet versus dry treatments. As you watch this program, please remember these points. This is intended as a resource, not a replacement for any of your training. Always follow your protocols first. If your medical director or instructor contradicts this program, listen to him first. In the field, make your decisions based on everything you've ever learned or experienced. Never rely on just one source of information. The authors of this program are Dr. Harvey Slater and Dr. William Goldfarb. As the founders of Burn Care Associates and managing physicians of the Burn Center at West Penn Hospital in Pittsburgh, they have considerable experience in research and providing burn care. Dedicated to educating burn care providers, they believe that proper pre-hospital burn care makes a difference.
I think it's important for you, the rescuer, to understand that you constitute the first link in the chain of burn care. We like to view burn care as if there were really 3 links in the chain of care. The first link being what happens at the scene and during transport, the second link being what happens in the emergency department, and then finally what happens in the burn trauma center. But truly what happens in that first link, both at the scene and during transport, can be a prime determinant of survival.
No matter what the situation, the ABCs apply. Patient assessment is always the first priority. Burn victims often have other injuries which must be tended to before the actual burn itself.
The rescuer must have in mind the concept that the burn wound itself has the lowest priority for treatment. Patients will not die of burn injuries alone in minutes. They will die of an undiagnosed tension pneumothorax. They will be rendered dead or quadriplegic if the rescuer doesn't realize they have a cervical spine injury. The patients will come to great disability or loss of limb if fractures and dislocations are undiagnosed. So the first thing to do is to restrain yourself and go through what you have already been taught in the management of every trauma patient. And that's to start with the fundamentals, the ABCs, the history of the accident, a complete assessment, treatment that is appropriate based on the findings, and the absolute last thing to do is to worry about the burn skin.
There are 3 major kinds of burns: thermal, electrical, and chemical. Each type of burn requires a different type of pre-hospital response. When any one of these is serious, it's obvious. However, a 4th category is not obvious, but is the most life-threatening: the inhalation injury. This injury often accompanies thermal burns. Inhalation injuries are also common for victims in closed spaces and firefighters exposed to smoke, high temperatures, and fumes.
Inhalation injury is really a complex event that can affect different areas of the airway, and it's in fact caused by different etiologic factors. We like to divide inhalation injury into 3 types. The most common type of inhalation injury is supraglottic injury, or injury above the level of the vocal cords. This is an injury usually due to the effects of heat. Heat leads to edema, and edema leads to obstruction. Remember, the amount of lipedema that you see, for all intents and purposes, parallels the amount of edema at the vocal cords. So the patient who presents to you with significant lipedema, hoarseness, and perhaps even stridor with respirations is a patient who has a high propensity for developing an upper airway obstruction. That's a very serious life-threatening situation which should prompt you to exercise almost a load-and-go situation. You need to communicate that information to the receiving emergency department. If you have the capability of obtaining an adequate airway, you certainly want to do that, but you do not want to delay transporting that patient to the emergency department. One of the second most common types of inhalation injury is due to the incomplete products of combustion, which leads to some changes in the tracheal mucosa. These patients generally have lower airway problems that will not be readily obvious at the scene. One third type of injury that is extremely obvious at the scene is carbon monoxide poisoning. Any patient who's been involved in an enclosed space fire has a high propensity for carbon monoxide poisoning. You should automatically assume that that is the situation, and one, after consultation with Medic Command, should consider initiating oxygen as the treatment for carbon monoxide poisoning.
The signs of inhalation injuries may include ashes or soot around the mouth and pharynx, burns on the patient's face, singed nasal hair, swelling of the lips, and hoarseness of voice. An obvious sign is when a patient coughs and has soot mixed in his sputum. Treatment for inhalation injuries must begin as soon as possible, before the physical symptoms start to show. Other indications should alert you to possible inhalation injury, such as what you know about the scene. If the patient was in a closed space fire or was unable to get away from the smoke or chemical fumes, suspect inhalation injury. This would include young children, infants in cribs, and elderly patients. It would also include substance abusers under the influence of drugs or alcohol. Firefighters overcome by smoke who seek relief with oxygen may have an inhalation injury which will seem fine one moment, then progress quickly minutes later. The longer the exposure, the more severe the injury will be.
Smoke inhalation is the killer of burn victims. Smoke inhalation is a complicated phenomenon. I want to briefly talk about the physiology of smoke inhalation and then the practical applications. We use the term smoke inhalation, not a respiratory burn. The damage that's done to the patient's airway is not because of the temperature of the smoke, but because of the chemical composition of the smoke. Burning wood, burning plastic, burning petrochemicals each create different compounds so that the extent of the injury is very different despite similar appearance of the patient's head and face and airway. So it's a chemical injury that's done by the smoke. Smoke inhalation is what kills burn patients because when we combine smoke inhalation and burned skin, you often have a lethal or at least very serious problem. Taken alone, a burn of, let's say, 15 or 20% of body surface area should be associated with survival in most children and adult patients. Taken alone, smoke inhalation should be a survivable situation. When we add the two, it's often lethal. There is an additive effect of smoke inhalation and burned skin.
There are three primary causes of airway and breathing compromise due to inhalation. Supraglottic edema is swelling of the area above the vocal cords and is caused by inhaling very hot air. Irritation of the trachea mucosa is damage to the lining of the trachea due to inhaling ash and other solids, and carbon monoxide poisoning caused by the fumes themselves. The symptoms can be subtle, however the injury may progress quickly.
How do you manage this at the scene? Again, go through the full trauma assessment. You want to be sure that the patient has a mechanically open airway, that it's not occluded by dentures, by vomited food, by fractured and loose teeth. Apply oxygen to the patient. This can be done by nasal cannula or mask. In rare cases, endotracheal intubation at the scene may be warranted. The patient should be transported in as close to a seated position as possible. We want to maximize the ability of the chest to expand and to move air. When you have the patient flat on their back, the diaphragms rise and the vital capacity, the room within the thorax to move air is diminished. When you sit the patient up, the diaphragms come down, greater vital capacity, they can move more air with each breath. This treatment at the scene can be very helpful. The patient must be seen at a hospital and often transferred to a burn center. The physical findings of smoke inhalation come late in most cases. When we have reviewed our own patients at our hospital, we find that in the high 90s, the 90% and greater have normal auscultation, normal chest x-rays, and normal blood gases initially. This is a treacherous injury. It must be suspected. Treatment should be initiated early and appropriate referral made.
Treatment for inhalation injuries includes early recognition, assuring a patent airway, providing oxygen, and rapid transport. In severe cases, intubation may be necessary. The life-threatening implications are immediate. For thermal, electrical, and chemical burns, life-threatening conditions are generally less immediate. Treatments are associated with longer-term patient care in the burn unit. However, there are significant procedures to employ immediately that can make a difference to your patient far into the future. First, we'll address those for thermal burns. These burns are caused by heat from flames, hot liquids, steam, molten substances, or heated surfaces. The damage caused by a thermal burn is greatest at the point of contact. The degree of damage is worst on the skin's surface. Burn patients will vary in their need for immediate care. Two criteria are assessed: the depth and surface area of the burns.
You need to be certain that you communicate accurate information to both the emergency department and in many situations directly to the burn trauma center. And there are really a few pieces of information that are of paramount importance. First, you want to be able to assure the emergency department or burn trauma center that the patient's injury is confined to a burn wound itself, and that there are no concomitant injuries that may be more life or limb threatening. Secondly, you want to be able to accurately communicate whether or not there is an inhalation injury, which may change the way the emergency department or burn trauma center is going to prepare to receive that patient. And finally, you want to be able to describe the burn injury itself. Specifically, you want to be able to communicate whether we're dealing with a partial thickness or full thickness injury, a combination of both, and what percent of total body surface involvement they can expect when that patient reaches the emergency department.
It is common that a patient will suffer from more than 1 degree of burn. Generally, you will find that a burn victim has combinations of degrees of burns. This makes evaluation more complicated because it's necessary to estimate the respective sizes of the degrees of burns. Your proper evaluation of burns and patient assessment can determine whether the patient should be transported to the emergency department or burn center, and allows early preparation for the patient at the healthcare facility.
Depth of burn is traditionally discussed in the United States as first, second, and third degree. First degree burns imply that the burn is superficial. It involves only the outer layers of the skin cells. The way you recognize a first degree burn is that it's red, it's dry, and it's painful. The common first degree burn that we should all understand very well is the sunburn. First degree burns in general don't require special treatment. They will heal. Simple over-the-counter creams to keep the patient comfortable, aspirin for pain, and the first degree burn gets well. A second degree burn involves deeper cell layers in the epidermis. The hallmark of the second degree burn is the blister. When you see the blister, you can be safe in presuming that this is a second degree burn. A third degree burn, by definition, means that the entire thickness of the skin is destroyed. Third degree burns appear dry, leather-like. They may be brown or black or gray, and they're insensitive to pinprick. The nerve endings